Good. Yeah.
I'm not sure you're aware people drift in over the course
Robin warned me, and I am aware. So.
We'll go ahead.
The broadcast is now starting.
Okay, well, good morning, and welcome to the ongoing Friday Medical Conference series. This morning, we are very happy to have with us speaking Dr. Jennifer Robohm. Robohm, yeah. She is a licensed clinical psychologist who relocated to Montana from New York City in 2003. She currently works as behavioral science faculty for the Family Medicine Residency of Western Montana and as a clinical associate with the University of Montana Department of Psychology. She directed the UM Clinical Psychology Center for close to 12 years before leaving that position in mid-January to focus on the residency program. In 2015, she completed a certificate program in primary care behavioral health through the UMass Center for Integrated Primary Care. Together with colleagues from the psychology department, she recently received a Montana Healthcare Foundation grant to develop an integrated behavioral health training curriculum. Dr. Robohm received her bachelor's degree from Yale and her doctoral degree from the University of Michigan. Welcome.
Thank you. Can you guys hear this? Is it loud enough? Okay. Good morning. Thank you all for coming at this very early hour. Looks like we were expecting all kinds of people to come to my talk. It's not true. I understand they've set that up for some kind of a conference tomorrow, so hopefully my voice will stay in this side of the room. Yeah, I work for the residency program and the behavioral science faculty, and in that position I work on patient-centered care, communication skills, helping to hopefully sensitize our residents more to mental health and behavioral health issues in their patients, helping them to work more collaboratively with mental health professionals. And that position has really evolved over time. 2 years ago, or 2.5 years ago when I started, I was a quarter-time position. I bumped up to half-time last year, and as Dr. Risi said, I went up to three-quarter time just a couple of weeks ago. And part of that is that we really want to develop our behavioral science curriculum to better address the needs that our residents are going to be facing. In our program, we are really trying to train folks to practice with rural and underserved patients. And so I was particularly interested in learning about what family physicians or primary care physicians in general are working with in terms of behavioral health issues around the state. And because of that, I conducted a study that I'll be telling you guys about this morning. Before I begin, I just want to have some acknowledgments. And first of all, thank the study participants. I don't know if any of you are in the room, but I really do appreciate that. Now that I've been working in the primary care setting for a couple of years, I now realize just how hard people work and what their workloads is like. I had no idea about that before. So I appreciate that even 10 minutes is a lot to ask of a very busy physician, so I thank those who participated. I also want to thank the Montana Academy of Family Physicians, the Montana Primary Care Association, and the Montana Hospital Association. They all helped me to recruit participants for the study, and I'm indebted to them. I want to thank Ned Vasquez and the rest of the residency program for helping me to buy out some of my time so I could work on this study, and also the fellowship program that I've been working with that's helped support me in the process. Okay. So what I want to do today is first of all define behavioral health and talk to you guys a little bit about what we know about how behavioral health issues affect healthcare utilization, healthcare outcomes, and costs. I'll share the preliminary findings from my study. And again, I was particularly asking physicians, what are the behavioral health issues you're seeing in your practices? And what kinds of recommendations would you have for us in training family physicians who are going to be working out in the communities that you serve? And I'm also going to discuss recommendations for changes in our system to better address those issues. I guess this isn't on the slides I gave to Robin, but I changed this from burden to challenge. I thought twice about the title of my talk afterwards, and I think there's a way where burden kind of implies that folks with these issues are doing something to us as providers. And really what I think our challenge is that our system isn't well equipped to either train or address these issues in primary care, and I think that's our challenge, is to figure out how do we do a better job of that. I get dry mouth when I talk, so pardon me for a second. So first of all, I just want to make sure that we all are kind of operating on the same page in terms of what behavioral health is. And I think we often think of that as mental health or psychiatric issues, that they're kind of synonymous. But I think of behavioral health as a much bigger umbrella term for all kinds of challenges that primary care providers are dealing with on a daily basis. Certainly the mental health and psychiatric issues, but also substance abuse, health behavior, patterns of healthcare utilization, either over or underutilizing care, non-adherence to treatment plans or less than ideal adherence. I think all of that, again, comes under the rubric of behavioral health when I'm thinking about what is the challenge that this presents for our system. Okay. So I don't know how familiar you guys are with the statistics in terms of what the behavioral health burden is. If I look at sort of the broader literature and look in terms of what percentage of our folks who come into primary care have behavioral health issues, I think it's something like 70% of behavioral health visits have some component of, primary care visits have some component of behavioral health in them. Folks who have behavioral health issues cost our system tremendous amounts of money, and I'll quote you something from the American Psychiatric Association. They did a study and they said that they thought between $26 and $48 billion a year would be saved if we were doing a better job of integrating behavioral and primary care health care. Just pretty profound. And they said that would be a reduction of 5 to 10% of our overall health care costs. So these folks are very expensive to our system. They also take an extraordinary amount of time. There was at least one study that said the average primary care physician spends something like 23% of their given work week working related to psychiatric issues in their panels. I don't know if that's consistent with your guys' experience, but that was pretty striking to me. And maybe even more compelling is even if our physicians really want to address these issues, the reality is that they have 3.8 minutes to address every issue that comes into them in terms of their patient's complexity. If you have 3.8 minutes to address a really complicated behavioral health issue, you're not going to be very effective. So overall, I think these issues are very prevalent. They take up a lot of time. They're very expensive. Folks who have behavioral issues are much more likely to seek care and often are not happy with the outcome. And so our providers are left thinking, well, what do we do with this? And that's what I hope the study is going to start to address. Just wanted to acknowledge too, in my study, I paid relatively short shrift to health behavior, although this is a huge piece of the problem. But I did want to stress that something like 48% or 40% of the morbidity and mortality related to medical care has to do with behavioral issues. So I said that wrong. So 10% maybe we can make an improvement in terms of the care we provide. 40% of a problem could be improved by changing health behavior. And providers know this, and we counsel our patients, but we don't really have time to do a great job of that, and so the behavior often doesn't change. That is certainly a very big piece of the healthcare burden, but it's probably not something I'll be able to talk about as much today. I see Annie Sondag is here from the university. Maybe she can talk a little bit about that later. Okay. The last thing I just want to say, and again, in our residency program, we're preparing folks to work with rural and underserved patients. And the literature out there suggests that in rural communities, people have higher rates of mental and behavioral health problems. They have worse access to care. Consequently, providers have larger caseloads and higher rates of burnout. So if we want to prepare our residents to go out into rural communities and deal with these issues, we need to better prepare them to handle them. And that's really something that I was thinking about in terms of designing the study. How do I prepare our residents to work in the communities that they're hoping to serve? Okay. So here's some stats on the study itself. We started by sending out a link to a survey through the Montana Academy of Family Physician listserv. And then we sent them out to MPCA and also MHA to try to get a few extra folks in. I ended up with 89 usable surveys. It certainly would have loved a bigger number, but I think the total, if I removed residents from that, was about 402. So it ended up being 22%. And again, I guess I'll say without using an incentive and knowing how busy physicians are, I was pretty happy with that. In terms of gender, over half were female. The age average was 47 years, but there was a range of from 31 to 67 years. We had folks who'd been practicing a very long time. The average was 15 years, but one of these incredible people had been working for 43 years out there and serving patients. I was happy to see that the respondents to the survey really represented a broad range of community sizes. I've collapsed some of the categories there, but we really had them from all across the state. And in particular, I was happy to see that 41.6% of the respondents came from communities where their practices had 10,000 or fewer people. And the reason I was happy to see that was we know a lot about sort of general statistics, but we really don't know enough about what are primary care physicians in really rural places, what is their experience. So the study gives us a little more insight into that. Also say that they came from a broad range of practice types. And you can see quite a range. The other category is a bit of a catch-all. There was Indian Health Service in there, critical access hospitals, VA, ER, a couple of people who were locums, a couple of people who did a little of this and a little of that. So it's a little hard to characterize people. We're probably a little heavy on university or student health service. Maybe that's thanks to some friends in Missoula, and I'm imagining from some other communities around the state as well. I did ask specifically if folks were residency faculty because I know they practice some but not full-time. And so there's 7 there. As far as I understand, all the residency faculty in the state are working at FQHC, so either at Riverstone and Billings or at Partnership Health Center here in Missoula, which means that our FQHC numbers are actually a little higher than that would suggest. Any questions about that so far? Okay. So to get into the meat of the study, the first thing I asked, as you can see, is what percentage of your patients have mental or emotional health issues? This is specifically mental and emotional, not including health behavior change. And the numbers were pretty striking, as you can see. So the average was 46.5%, so close to 50%. If you look at SAMHSA numbers in terms of prevalence of mental health diagnoses in the overall population, I think it's 18.1%. So, and that's for folks who really meet diagnostic criteria for serious mental illness or more specific diagnoses. So I'm not surprised the number is higher, but I am surprised it is as high as it is. And I would add that there was some variation in terms of practice locations. So for the FQHCs, the number was actually 67.9%. For those of my residents who are here in the room, that probably doesn't surprise them because they tell me that almost all of their patients have mental or behavioral health issues, and in some ways that may well be true. But I think how much of this burden you're addressing as a primary care doc is going to depend in part on the community you're in, or at least the practice facility you're in and what population you're serving. And it doesn't surprise me that in a safety net clinic we might be seeing more mental health issues. Is that number kind of consistent with what people would expect? The next thing I asked was about what percentage of your patients could benefit from health behavior change. And this number, maybe not surprisingly, is higher. I suppose if I asked all of you, we might have 67 or whatever % in the audience would need to change their health behavior. But again, part of what was interesting to me in here was in terms of some of the differences. And if I look at the community health centers, again, their average was 81.4%. So they're significantly higher than other types of practice settings. Again, I think this just speaks to the volume and the high prevalence of the mental health and the health behavior change needs in our primary care populations. I asked folks about what is the most challenging psychiatric or a behavioral issue that you have to deal with in your practice. These aren't percentages because this was sort of an open question. Not everybody responded to it, but some of the findings I think were pretty striking. Substance abuse surprised me that it was as high as it was. That also, I subsumed under that drug seeking and other things, so that might be bumped up a little in terms of that or maybe diversion issues. But substance abuse and alcohol abuse are pretty serious concerns for a lot of the providers out there. Personality disorders, and again, that may be less about how do I treat this and more about how does this impact me in the patient-provider encounter. Bipolar disorder, psychotic disorder, you can see health behavior, that included things like obesity. I was a little surprised to see chronic pain as low as it was. I think that's probably because some of those folks were subsumed under substance abuse in terms of drug seeking or opiate dependence, things like that. But this just gives you a general idea of what folks were saying were the most challenging problems that they had to deal with in their practices. This is a busy slide and it's a little confusing. And in part because I didn't ask exactly the question I would have wanted to in the interest of keeping the survey shorter. But I did ask folks about recommendations they had for the training of our residents. What kinds of skills and interventions did they think they needed to be trained in? The scale was 1 to 4. 4 was an essential or core competency. This is something that people have to have. 1 was something that's not used very often in practice. And so the way I interpreted that is if something got a 4, somebody said they absolutely have to get this training. If they got a 3 or 4, I thought that was probably a priority area in terms of training. What struck me is if you look at the overall the 3s and 4s, that every single one of those behavioral skills and interventions, people said at least 50% and usually 70 or more said this is something that folks really need to be trained in. I can explain what some of those categories are, but I'll get to that a little bit later in more detail. But just to say that I think this would imply, at least by proxy, that people think these are skills that we need to try to address these problems in our practices. What I think is maybe more compelling is when I ask folks, well, what gets in the way of your actually using these skills? So even if you have these skills and you like to do them, are you always able to do it? And the answer was clearly no. And I think the take home, the biggest two are the top two there, which was 97.5% of people said either frequently or some of the time gets in the way. So I might have the best skill set in the world, but if I have 1 minute to do it, I'm not going to be able to do anything in that amount of time. And of course, competing medical priorities was another. If somebody comes in with 5 issues, I may not be able to give their depression the time that it might deserve or that I might give it otherwise if my hands weren't so tied. I also asked them about things like comfort and knowledge, and I'll talk about that more a little bit later. I put a star by warm handoff because that's not actually an obstacle, but that was something that might interfere or at least limit how much somebody used a skill, which was if I had somebody in my clinic to hand that problem off to, that often either frequently or sometimes determine whether I use that skill or not, which makes sense. So I asked folks how effective they feel in addressing these issues, and this is a little confusing. This was on a 7-point scale from strongly disagree to strongly agree. And the average for feeling effective in terms of mental health issues was somewhat agree. That was actually a little higher than I expected. And it was significantly lower in terms of health behavior change. So, and I don't remember what P level, but there was a significant difference. People felt much less effective dealing with health behavior. Again, we could speculate why that might be. I think if I'm dealing with, say, depression, at least I can prescribe an SSRI. Whereas if somebody's not changing their exercise, I might feel there's very little that I can do about that. And so that would be my guess about why those numbers are like that. And effectiveness, as I wrote there, it wasn't impacted by location or degree of integration in the practice, your years of experience, how much your training emphasized behavioral science. I didn't quite know what to make of that. Again, I kind of joke with myself, either physicians kind of overestimate their effectiveness overall. More likely it wasn't a very sensitive question and it really didn't get at what I was trying to measure. But what I take away from this is that folks are feeling somewhat effective, which is good, but not as effective as certainly we'd like them to be. One of the things that I thought might help people feel more effective is if they had resources in their practice locations. So these were the types of providers that you might have actually available in your location. I added substance abuse counselor at the end because I forgot to ask that, and I've been kicking myself ever since, especially given that was such a challenging problem for a lot of the providers. But you can see that a lot of the folks actually had access to some of these things in their locations. Some of that surprised me a little bit until I looked at the service location types themselves. And specifically, some of the settings like an FQHC, you were much more likely to have a mental health counselor if you worked at an FQHC. The University Health Services folks had better access to psychiatry. And I think if you looked at outpatient, I think it was hospital-owned clinics, FQHC, and residents, that accounted for two-thirds of the social workers. So once you eliminated certain kinds of practice sites, folks really didn't have very much access to some of these kinds of resources to help them out. This was, to me, one of the most interesting questions, and I'll talk more about it later, but I used the SAMHSA levels of integration. I don't know how many of you guys have seen that. Minimum basically means I refer people to other folks out in my community. We don't tend to have any communication really after the referral. Basic at a distance, we might talk a little bit, especially if an issue comes up. We might consult occasionally, but again, we're in separate locations. We're not spending a lot of time working together. Basic on site might be I have somebody maybe at another part of the hospital, another part of the clinic, and I can refer there. They're usually a specialty mental health provider as opposed to something more integrated. That certainly makes the referral easier because they're on site. Close on site means it's much easier to make a referral. Sometimes maybe we are involved in huddles together, or we have some occasional case consultation meetings, things like that. Close integrated means there's a little more integration. Probably the EMR is connected. Maybe we are doing huddles regularly. We're consulting more regularly. And 6 is really more of a transform practice where everything's about integration, and folks are very much working on an integrated team where there's a shared treatment plan. We're really thinking together about how we're treating each one of our patients. For me, the biggest take home from this is if you look, close to 50% of folks are in those first two categories. So they're making referrals to folks who are at separate locations in their communities. And we all know that, well, maybe you don't know, but something like 10% of people, when you refer them out to the community, about 10% of them actually make it to the initial appointment. So there's not a whole lot of integration or working together there on the behavioral health issues. I was surprised and pleased to see that 9.6% of folks are saying they're working in more transparent practices, and I'd love to know who those folks are and wish I could track them down because I'd like to see what they're doing. But I think that's a good sign. But suffice it to say that, and I don't know how this compares to other parts of the country, but suffice it to say that Montana isn't a particularly integrated state. And I think there's sort of a bias in the literature that more integration is better. And I think there's some real limits to that way of thinking, in part because you can't afford integration unless you have a certain volume a lot of the time. And we work in very small communities, a lot of us. So integration is going to probably be harder to pull off in Montana than in other places. But if we're trying to think about solutions to the problem and how best to address these issues, and folks have very little time in which to address these problems, finding ways to have more integrated care with behavioral health providers would seem to me an important solution. And we'll talk about that. The last thing I want to talk about, again, was difficulty of referrals. And I collapsed the categories here, but there was, and this won't surprise most of you in the room, there was much harder, significantly harder for folks to make a referral to psychiatry than to mental health. But if you look at even the mental health counseling, folks were not saying they had an easy time with this. And this was worse if you were in a smaller community. Both of these were significantly harder, which again makes sense. There are fewer providers, and especially given how many of our communities are mental health professional underserved areas as well. But folks are saying we have all these problems. We don't have a lot of people on site, and it's really hard for us to make referrals off site. So it's obviously a big challenge. Okay. So now I've spent all that time talking about the problem. Let's talk a little bit about solutions. I changed the slide a little bit, so sorry for folks who are seeing it elsewhere. But I asked the physicians if there were systems changes, resources you needed, training that would help you. What are things that you would what would help you to better address these problems in your caseloads? Again, this was a free-form question. Not everybody responded to it. So these are more mentions. But this is what folks said. I was actually surprised that 19 folks talked specifically about integrating services better, especially since I'd asked that one question only about integration. And that makes me think that this is on people's minds. If they've heard about these concepts, they're interested in them, they can recognize why that would be helpful, and maybe they're not sure how to get there. But 19 of the physicians said that they'd like to see more of that. Not surprising, 19 said they'd like to see more psychiatry, either places to refer, people to consult with, pediatric psychiatry in particular. Folks were saying they had less access and less knowledge, and they needed more of that. Behavioral health training, again, they were probably primed a little for this since the whole study was about what would you recommend in terms of how we would train people. But in terms of helping them with their jobs, they also said they needed more training, and I'll tell you in a second what specifically. A lot of folks said they needed more counselors in their community. They needed better communication with their counselors. They needed higher quality counselors. I would say for both psychiatry and counselors, some folks said I have them in my community, but I don't think they're very good, and so I don't like to refer to them. So that's a problem. They also said, especially for counselors, we need more folks who are willing to work with underserved people and people without resources, because we have maybe, Missoula is, I think, a good example. We have lots and lots of therapists here, but not as many who will work with folks who don't have a lot of money. Inpatient access came up in terms of both long-term care and short-term care, and specifically timely access to inpatient services, maybe more beds. Telemedicine came up, and I think that makes sense, especially for rural communities where we're not going to be able to get folks in there, and I know St. Pat's is working on some of that. Care management services. Some folks specifically talked about funding changes, and they talked about value-based care instead of fee-for-service. If we think that working together as teams is a better way to go, but we don't get reimbursed for any of the integrated stuff, that's a problem. Addictions treatment, a couple of folks specifically said more time. If I spent less time on the EMR and less time doing ICD-10 coding, I might actually be able to use my counseling skills. And somebody specifically said more physicians, and of course that's part of why the residency program exists, is to get more physicians out there. But the top three were, I think, most compelling, and since I have my hand directly involved in two of them, I'll speak to those for the remainder of my time. Okay. The way I think about our training needs is really two-pronged, and one is to train our primary care providers to be attuned to mental health issues. especially I would say those who are hoping to work in primary care settings, because the physicians who responded to the survey are very clear that you need these skills if you're going to be effective out there. I didn't ask about this in the study and people didn't talk about it, but I'm certainly going to put a plug in for we're going to need to do better training for behavioral health providers. And I can say, having been doing this for a couple of decades now and having not been trained in integrated care, this is really a new area. I think sometimes physicians think, oh yeah, mental health people know how to work in these settings, but we don't, because it's a totally different culture, different language, different patient population, different way of conceptualizing care. So we really need to revamp our training programs in terms of mental health to prepare people for working in primary care settings. And that's part of why we applied for that grant through the Montana Healthcare Foundation to develop a curriculum for that. And hopefully in the future we'll also be adapting that so that folks who are out in the community can, and practicing now, can kind of get retooled to have more skills for primary care settings. There are programs like the UMass program that I did last year out there, but that one cost $1,800 and my department paid for it. And folks aren't going to be able to afford that out in communities. So we're hoping that we'll be able to develop a resource that people can have access to for free or low cost so that they can feel like they can get more up to speed. And then overall, I would say everybody needs to learn how to work together better with each other. And again, a lot of us have been trained in our own silos, and then we're asked to work together as teams, and we don't really know how to do that. And so I think we're hopefully getting smarter about that for folks who are in grad school or who are in residency training. Now's the time to learn how to work well with others so that when you're out in the field, you can do that. In terms of what they wanted, this is what the participants in the study said would be helpful to them in terms of education. And I think probably maybe continuing medical education could address many and all of these things. I'm sure there are some offerings that do now, but this is what folks mentioned as things that would be helpful to them. Particularly found the last one compelling. Somebody talked about self-care and how to get help, and stressed that physicians out in rural communities in particular are very, very overwhelmed. A lot of them are self-medicating, this person said, and we really need help in terms of taking care of ourselves. You know, I think the burnout rate is something like 54.4% in terms of family medicine physicians. I think these behavioral health issues probably have a large contribution to that problem. But I think it's important to keep training folks in how to be as well as they can. Some of those I'm sure those topics aren't particularly surprising to folks, but folks are saying, yeah, I want more. Motivational interviewing came up a lot, I think, again, because of that overwhelming burden of health behavior change. This is the data from before. I know it's a very busy slide. This is the data from before in the bar graphs, but I wanted to give you guys the exact percentages in terms of what folks said that they thought our residents should be prepared in. So again, thinking about as we're getting the next generation of physicians ready to come out into these communities, what are the skills that they need to have and the interventions they know how to provide. And you see, again, priority, I'd say that was the 3 or the 4, and then the core competency was what folks said they absolutely had to have this skill. And patient-centered interviewing, so 2/3 of folks said this is a core skill. That's good. I spend quite a bit of time on that now. But they really endorsed all these other things, at least to some extent. You can see it's quite a range of skills and interventions that folks might need to use when they're out in the field. I wanted to read a couple of quotes specifically from folks who are in rural communities because I thought that was kind of powerful. And 3 of these 4 people have been practicing for several decades, and they were all in communities of fewer than 1,000 people. So I think this is a particular voice that we need to hear more of in terms of how do we prepare folks. One of them said, rural medicine has minimal support by mental health systems. Those planning this lifestyle should get advanced training in behavioral and mental health techniques. Montana has an almost unusable mental health system for rural communities. So again, who do we refer to? There's always been a need to integrate behavioral health care into primary care practice. I don't see this happening for rural practices in the near future, partly as a result of limited resources. Thus, it's very important for residents to know not only how to care for physical illnesses, they must also know how to manage behavioral issues. And the last said, training in collaborative practice is important, but independent skills must be developed, or the ability to practice successfully in small and rural practices will be very limited. This from somebody who I think had been practicing for over 25 years or 30 years. This is a slide. I found this one really interesting, and I'll tell you why. First of all, I like that my scale goes up to 120%. I don't really understand that, but nobody said that that many people needed it. I asked folks about the emphasis on behavioral science in their residency training programs, and it went from no, some, moderate to major, and I kind of split them into halves. So the high emphasis in behavioral science training and the relatively low emphasis in behavioral science training. We were pretty split down the middle in terms of the sample. Actually, more than half said that they had relatively low emphasis in behavioral science in their training. And maybe this is my soapbox for a second, but if you look at the numbers of behavioral health issues that people are dealing with in their practices, and we think about the number of, or the tens of thousands of hours that folks spend in medical school and in residency training, and we think about how relatively little emphasis there is on this in training to prepare people, you can understand why people feel ill-equipped to know what to do with these problems. It was striking to me that of the 7 faculty members who responded to this, 6 of them said that they were in programs with relatively low emphasis on behavioral science. So if I'm thinking about faculty who are preparing the next generation of folks to deal with behavioral science issues, that's a little worrisome to me. And I think it's part of why family medicine now requires that there be a behaviorist on all faculty, recognizing that we need to make sure that these issues are addressed in the curriculum. There may be some self-selection that goes on too. If I looked at there were only 4, but there were 4 physicians who worked in solo outpatient practices, and every one of them had been in a program with a relatively high emphasis on behavioral science. And it might be that they chose those programs knowing that those were the communities they wanted to work in, or it might be that they felt more comfortable going to those communities because they felt that they had the skills that they needed. But either way, I thought that was interesting. And then I looked at this FQHC, CHC numbers, and 8 of the 12 came from folks who were working in those settings, had been in relatively low emphasis programs. 2 ways of thinking about that. One is if I don't feel like I know how to do this work very well, or it's not my cup of tea, I might work in a setting where I know I can do a warm handoff and somebody else will take care of that for me. It might be really smart. It might also be that folks are working FQHCs for all other kinds of reasons in terms of mission or loan repayment or whatever. So I don't want to put too much into that. But I do think it's striking that for the folks who are working in the settings with the greatest need, a lot of them don't have a lot of preparation or relatively less preparation in terms of behavioral health. I guess I'll say one other thing, and I know the residents and Ned have heard me talk about this a lot, but we practice, or we prepare our residents in the state in FQHCs. So all of our doctors who are hopefully going out into medically underserved and rural communities, they're all being trained in facilities that have the ability to make a warm handoff, which is great. I think this is potentially our service model of the future, and we want people to know how to do that. But if we're training our physicians to go out into the communities with these high needs where they're not going to have these folks in their practice, there's a way where we may be doing a disservice in terms of actually preparing them to have the skills that they need to do this work. So it's just something I think we have to think about. All of our residents right now are training in FQHCs in terms of their continuity clinic. Again, I'll just put a plug in for behavioral health training. I said this before, which is that I think we need to train how we're preparing folks from the mental health and behavioral health end of things. And I wanted to give a nod again to the curriculum that we're hoping to develop right now. There's David Schulberg, a colleague from the psych department, is teaching a class for our grad students looking at integrated behavioral health. And we're going to try to include more social work and counselors ed students in the future. David was also a part of a grant-supported pilot project along with Western Montana AHEC that has placed advanced grad students in psychology and social work out in rural communities around the state to be integrated into service settings. And it's kind of the same idea that we have with the residency, which is if they do their final training in a rural setting, they might be more likely to stay there and also get more practice in terms of integrated care. And those folks have been in Plains, Libby, where else? Okay. Deer Lodge. So it's a way of, again, getting some folks trained in integrated care around our state, which I think is great. And the Montana Medical Association has been working to try to get some certification for health behavior coaches so that we can get folks out into communities. And I know Annie's been working with folks at the university to get folks better trained for that too. That to me makes a ton of sense. If you get relatively inexpensive people out there really helping and working on health behavior change problems, hopefully that will assist physicians in that regard too, since they feel so ineffective and don't have the time. I wanted to spend the remaining of the time talking a little bit more about integrated services, and this is a little less about what the study said and a little bit more about what I know about integrated care. There's certainly a large push in this direction from a lot of places. NCQA, in terms of the patient-centered medical home, integrated services is now a requirement starting in 2014. So folks who want to be PCMHs are going to have to provide some kind of integrated services. The National Rural Health Association also recommends integrated care, again, trying to figure out how do we address the burden. And part of this is primary care physicians are overloaded. There are not enough mental health people. How can we help them both deal with the problems that are out there? And Family Medicine for America's Health, this is sort of this new initiative to restructure how we think about the healthcare system to integrate both mental health and public health and primary care all together. So there's a lot of folks who are really thinking in terms of integration. I'm not going to do these. I'm just going to talk a little bit about some of the models that are out there. And there's really a continuum. And again, I want to stress that there's not a right answer. And in terms of integration, part of what makes sense is what makes sense for your facility or your community based on what the needs are and what your resources are. Oops. For some places, integration is going to mean just improving collaboration and communication. If we have better referral systems and we have a better way of sharing information about our shared patients, even if we're working in separate systems or in separate facilities in the same community, it's still going to improve how well we're integrated. And for some places, that's going to be what they can afford right now, and that's great. But I think working on making those communication systems and referral systems work better is an important piece of integration. In some places, just giving more information, more ability to consult for medical providers would be helpful. So this might, again, be some telemedicine, consultation, liaison stuff. Maybe Laura, you can speak to this a little bit later in terms of what St. Pat's is doing, but behavioral precepting, I do some of this in the residency. So it's not so much that we're giving people places to hand things off to, but at least we're helping them to deal with the mental health or behavioral health issues in their practices. Co-location. So, and again, I think this is happening more and more where maybe there's somebody from the community mental health center who's on site in your location and you have an MOU with them and they're doing work in your facility. Or you have a master's level counselor that is working in part of the clinic. Most of those, when it's co-located, usually they're providing more traditional mental health. So I'm making a handoff, but they're doing, a 50-minute psychotherapy appointment. And that's still a very different model of care than some of the more integrated models that I'll talk about if you want me to. But it's still a lot easier to refer to somebody if they're in the same building. And the chances of that person making that appointment is going to go up, obviously, if they're just across the hall. Some places are using more integrated stuff. Again, they might embed somebody in the clinic, so you can maybe just walk them right over. But again, these are still more traditional psychotherapy models, and not so much, not so much this kind. So there's the collaborative care model. This is what we have at Partnership Health Center. It's the IMPACT program is what it's known by. And this is where you have care managers who are often they're looking in a registry, they're providing screening, they're identifying people who have a certain problem. It's often a high need problem in a clinic or something that's very prevalent. It might be diabetes, it might be depression, it might be people with diabetes and depression, but you're often looking for your high utilizers or your most expensive folks and you're trying to figure out how do we address the need here. So if we identify them and then follow them really closely and measure their outcomes, we're hopefully going to get better outcomes. And in fact, we're finding that at Partnership. This final model, and this is actually one of my favorites in part because I think this is easier to integrate into smaller clinics or facilities. This is the primary care behavioral health model. And this is a model where there's actually a behaviorist who's right there in the clinic. You do a warm handoff. Often they see the patient in the consulting room. The doc may move on to their next patient, and the behaviorist is in there working for maybe 15 to 20 minutes. So it's short sessions, and it's not traditional psychotherapy. It's fairly problem focused on self-management of the problems. You might give them a lot of homework. It's really thinking in terms of population health. So I'm not solving this person's problems or taking away all their symptoms, but I might help their functioning improve a little bit more. And the idea is if you're giving this service to more of the folks in your clinic, the overall population health is going to improve. It's a very different way of thinking, and part of it is you're also thinking your patient or your customer is really the primary care doc, not the patient. I'm in the clinic to help my primary care doc do a better job of addressing the needs of this patient. And we're working together as a team, and I'm consulting with them and helping them figure out what does this patient need to get better? How can I help you, the physician, to do your job more efficiently, more easily, help you to feel more effective? So it's a very different way of thinking and practicing than traditional psychotherapy, but I think it has a lot of exciting potential for helping clinics. Okay. I'm not going to talk about those either. In terms of some of the more higher integration models, I think there are some sort of core elements which you can see up there. Part of it is a common consent, so that when folks come in, they know I might well see a behavioral health person too, even if it's a primary care clinic. There's a clinic in Colorado, and they have, I think, 9 clinics around the state. In their model, every single new patient who comes into the clinic actually sees a behavioral health person before they see a medical person. So there's a screen for mental health issues, there's a screen for substance abuse, for life stress, health behaviors that they might like to change. It gives this very, I think, profound message. We think behavioral health is part of your overall health, so much so that we're going to start there and identify these problems up front so that your physician and I can work together to figure out what it is that you need. I think that's pretty cool. And I'll tell you that doc said at one point their program was grant funded, and when the grant ran out, some of his docs came to him and said, you know, if you want to not give us an increase this year so we can keep paying for the behavioral health people, please do that, because we can't imagine working without them. And I think in partnership, it would be really hard to imagine at this point, if the impact program went away, how easy or hard it would be to address folks' needs, right? So I think the same thing happens. Often when physicians see what's possible with an integrated program, they never want to go back because it just makes so much more sense, right? Unified treatment plans, so you're really thinking together, what does this person need? And we have multidisciplinary rounds regularly with the physicians and the behavioral health team so they can talk about their shared patients. They can see each other's notes in the EMR, so it's not like, oh, what we do in psychotherapy is over here and what you do is over here. Everybody can see what everybody is doing, which I think is really important. And there's systematic tracking, and at Partnership we use the PHQ-9, and the impact folks are tracking people's scores on that regularly to see if people are improving or not. If they're not improving, they might have the consulting psychiatrist come in and take a look at the meds and see if maybe something needs to be tweaked. And the idea is you're monitoring closely and following it closely, which I think improves outcomes. Okay. I'll just say what the literature says in terms of integrated programs is maybe not a surprise. They have better health outcomes. When people get sent to the behavioral health, they have much better attendance. So it goes from as low as 10 to as high as 90. That's pretty impressive. It makes sense. If I have to walk you across the hall, it's hard to lose you on the way there. People in general feel like there's less stigma. I'm in the same waiting room as the primary care patients. Nobody knows why I'm here. They don't know which provider I'm going to go see. It's just understood, again, that we're addressing health here more broadly, and I see different providers for different aspects of that. There's less stigma, and I think there's convenience. There's sort of that idea of one-stop shopping. You know, at Partnership, people can get their dental care, they can get social work, they can get medical care, they can get behavioral health care. They know where the parking lot is, they know where the clinic is. It's just easier in some ways for folks to get it all in one place. Since this sounds like such a great idea, I think it's, well, why isn't everybody doing this? And there are a lot of reasons for this. Some of them are at the national level. You know, it's hard to recruit folks to work in these, especially when they haven't been trained to do it, and we're working on that. There are some issues in terms of regulations, in terms of who can provide behavioral health services. You know, in some community health centers, it's a struggle to be allowed to bring behaviorals in just based on their state regulations. Reimbursement is a huge issue, and we're still working this out. So a lot of the programs out there that are finding really great outcomes, they're grant funded, and when the grant goes away, the program goes away, or people start to limp along more. And I think that's something that really needs to be addressed, and I think is being addressed when folks are thinking about value-added programs instead of fee-for-service programs. You know, once you're starting to think about how we're measuring the health of a population, and we know that integrating services helps us to do that more cost effectively, I think people will be more inclined to use these models. And I also think a piece of it depends on educating third-party payers. So I wish Barry Kenfield was here, but Larry, you may know this, but I think Blue Cross and maybe it's Medicaid, a couple of payers in our state are now reimbursing for something called health and behavior codes. And that's when you have a behavioral health person addressing a health issue in a short-term intervention. You can actually bill for that. Unfortunately, right now, I think only psychologists can bill for that, not counselors or social workers. And so that's something we need to look at. but there are some new reimbursement mechanisms to help us address some behavioral health issues in primary care settings. I think in some ways some of the practice barriers are the biggest, and I appreciate my residents' kind of patience with me as I've gotten more used to the primary care culture. Having worked in more traditional settings for 20 years, it's been a real challenge for me to learn how do I adapt to the pace and the language and the vocabulary and the kinds of patients that you see in primary care. They're really very different worlds, and I think that's a barrier. You can't take a traditionally trained person, put them in a primary care setting and expect them to be successful. They just won't be. And so that's, I think, been a barrier until we get people more trained up to speed. There are patient level barriers. Folks might have bad insurance and not be able to pay for it, or they, any number of reasons why it might be hard for them to come in. They might still feel stigma about mental health and turn it down. And some of them may just prefer, in fact, I know folks will sometimes say, oh, that model, that impact model is nice, but I really want to do counseling like I've done it before. And in some ways, that's about changing patients' expectations of what kinds of services we provide and why. If folks are used to meeting on a weekly basis for 50 minutes, it's hard to switch to a different model. But that traditional model is working really well for the 8% of people who have access to it. But the other 70% who are coming into primary care settings, we need a different tool. There are folks who are actually doing this, and if for those people in the room or folks who are dialing in, I think it might be worth talking to folks. So again, partnership, we have the IMPACT program. The VA, Veterans Health Administration in Missoula, they have an integrated program that's more like the behavioral health consultant model. And the VA is really advanced in terms of integrated models around the country. So if folks might want to talk to the folks over there. Again, I talked about the pilot program with AHEC and the psych department in the School of Social Work, which is, I think they even won an award because it was innovative and exciting. And Providence, I know, is about to integrate all of their patient-centered medical homes with LCSWs in the next year or so. So we'll see how that rolls out. In terms of folks thinking about how do we integrate our programs, I think there are any number of considerations. And really, first of it comes down to how ready is our facility to take on integration? And if so, if we know this is something we want to do, what are the resources that we have available and what's our need? So I think that's part of the needs assessment process that has to happen. Are we trying to serve the whole community or just our patients, that we have in the clinic now? Well, what kinds of behavioral health problems do they have? If we're being overwhelmed by depression or overwhelmed by substance abuse, maybe we'll focus on that. Also, how severe and complex are the problems that people have, and what are the other resources available in the community? If I have a really great high-functioning mental health center, well, maybe I can send more people over there. But if I'm in a rural community where that doesn't exist, I might need to think about how do we address those problems here. And that will affect the balance in terms of more traditional psychotherapy services and more behavioral health, say, consultant services. If there's no therapy available in the community, especially for low-income folks, you're going to have to do some of that in your clinic, most likely, which is what partnership does. It does a little bit of both. And so a piece of it is understanding the needs of your patients and maybe talking to your providers about who are the folks that you're struggling with the most, who are the ones who make you late during clinic, who are the folks you feel are not improving, and maybe figuring out, well, how do we address just that? And some programs do that. They start with one problem area and they really try to tackle that, and others try to do something more general. Again, it really depends on your clinic and what you think your biggest needs are. You also have to check on administrative buy-in. If you're not going to make this happen unless your administration is on board. And you're going to need at least one real physician champion who really thinks this is important and thinks it's an exciting idea, is going to help usher it through. Because as nice as I might be as a mental health person coming in and saying, this is what you guys need, that's not going to fly very well. You need to have physician buy-in and input and to say, no, we really think that this is important in our setting. And that will help to make it happen better. I'm forgetting a couple other things I would add to that. I guess the other thing to look at is what are the skills that your staff has. You may have some people who've really been trained in integrated models, or you may not, in which case you might have to really beef that up to make your program successful. But in general, I think the research shows that being really transparent about what you're doing, being well organized, getting a lot of input, and being flexible and ready to change it and adapt as you go are good solutions to be a more successful program. I already addressed this a little bit, but I'm going to address it again because I think it's critical. A lot of the folks who are doing integrated care, they're doing it based on grants, and that's got to change, or this is not going to be a sustainable model. I will say this is an exciting time to be in Montana because of the Montana Healthcare Foundation. They're funding integrated programs and partnerships, and so if folks are looking for new funding streams, there's a grant cycle open right now, so take a look. Again, partnerships might be an option. There are some, especially if they're larger organizations, they might decide we're going to pay for this out of our internal operating budget because it's going to improve provider satisfaction, it's going to improve our outcomes, we think it's worth it. And especially if you're bringing in, say, a master's level person or our care managers in the impact program are BA level people and they do an awesome job. You can bring in folks who are a whole lot cheaper than physicians to take a big piece of this burden off the physician's plates. There's a very good chance it's going to pay for itself. I talked about the health behavior codes and I talked about value-based reimbursement too. So in conclusion, first I just want to acknowledge that there were some limitations in my study. I don't know how different types of physicians, different types of practices are actually distributed or represented around the state. I think, for example, we oversampled from University Health Services. I had one respondent from Indian Health Service, so I'd be very interested to know what's happening more in our Native American communities, and I don't have a good way of assessing that. And again, I didn't ask people about substance abuse, and I'm going to kick myself forever about that. But nonetheless, I think there was some really useful information, and I think it's probably pretty consistent with people's experience, which is that we're seeing a whole lot of behavioral health, and it's really hard, and we don't have the resources that we need, and that's got to change. So I do think we need to be creative and innovative. I think we need to beef up our training. I certainly feel a little more reinforcement for the work that I do in the residency, and I'm going to keep pushing forward. I think it's important to give folks the skills and the information that they need. But I want to really stress, I think we need to act now. And part of this is there was a whole lot of frustration expressed in the survey in terms of people feeling overwhelmed by this stuff, not feeling like they have the support maybe from their administrations, not feeling like they have the tools that they need. They trained for many, many years to work with a lot of medical problems, and what they're seeing is a whole lot of behavioral health. And maybe we need to change people's expectations, but I think we need to give them more help so that they can focus on the stuff that they feel really well equipped to do. And I do think integration is one really potentially powerful way to get there. One of the things that I took away, and I think this is a challenge that I wrestle with every day, is again, how do I train residents to work not only in the practice setting they're in now, but in the practice settings that they may be in the future, especially because a lot of those settings won't be as integrated as we might like them to be. And I don't have the answer for that yet. I'm working on both levels, but I do think it's a challenge that we train residents in relatively integrated sites and then we send them out into less integrated places and say good luck to you, because I think that's a problem. And hopefully we'll be doing that, maybe intersecting a little bit more with some of our rural rotations in the future to find out what those communities need and maybe figure a way to synchronize things better. Overall, I'd like to say, and I think the research is supporting this, that I think integration is a really important direction for us to be heading in, and I do think it's might help us address what people have talked about as the triple aim, and somebody else has added as the quadruple aim, which is that the levels of burnout are so high for physicians. I do think that this isn't substantiated by my study, my personal opinion, but I think the behavioral health burden is a huge reason why people are feeling overwhelmed. It makes them feel ineffective. They don't have the tools that they need. It takes a ton of time. It sets them behind in clinic. It's a huge stressor in terms of practicing physicians, and we have to address it better to take better care of our docs. I'm going to conclude. This was a quote, but I thought it was pretty striking. This is from one of the participants. So if anyone actually reads these suggestions and actually takes steps to make any of them happen, it would be a huge improvement in caring for our patients with behavioral health issues and improve the mental health of providers, and maybe even bring back the feeling we once had that we can make a difference in our patients' lives. Thank you.
We have time for questions.
2 minutes. Yeah, sorry. Tim, go. In the impact program, they use...
Have you repeat the question, please?
Sure. Tim asked what are the therapeutic modalities that they use in the impact program at Partnership Health Center. And the two things that they focus on a lot, the BA level care managers, they focus on behavioral activation, which is a modality that's been shown effective when we train health behavior coaches and nurses and docs, and it's relatively simple to train in. and it's basically helping folks to get more engaged in activities to help boost their mood. And it's a quite effective modality. And the other one is something called problem-solving therapy, which again is very solution-focused. You help somebody pick one area of their life that they want to work on. You problem-solve with them. You get them to practice it. And usually, you know, a lot of folks with depression, they're not feeling very effective in terms of coping. So if you help them address one key problem in their lives, it tends to improve their mood too. And again, you may not be improving their overall health, but if you're helping them address one problem, you're probably improving it enough to get them out of the severe depression area. So those are the two things that they work on most. Yeah, Megan.
So Montana has a lot of programs to help physicians or medical providers prepare for rural sites like the residencies and the trust with the UW School of Medicine. But does the psychology department have things that prepare behavioralists for rural experiences, like rotations through the clinical psychology center or anything like that?
It's a great question. I think everybody heard that now, right? We haven't up until now, and actually there are very few training programs around the country that specifically focus on rural practice, which I think is a real issue. David's seminar, part of it is focusing specifically on training in rural areas. What are the particular needs that rural communities have that others don't? And again, I would love us to find a way in the future to have rotations for psych students as well, maybe along with our residents in the rural communities so that they could be practicing and learning together in integrated models out there. I think that would be really exciting. And I know, I will say that our residents, our psych students have been extremely interested in this. In this last couple of years when we've done their internship matches, the vast majority of our students have gone on to placements with integrated behavioral health care and primary care psychology rotations in them. They know that this is the direction our field is headed in. And I think in Montana, maybe we have a particular responsibility to train folks for rural communities since we're trying to keep them in state too, just like the residencies. But that's a great question, Megan. Yeah.
I think it's really interesting that you make such a strong distinction between rural and urban in Montana because you really, I mean, having practiced in Missoula for 35 years, everything you said there about the rural communities, I could say was characteristic of my practice in terms of behavioral health accessibility, in spite of the fact that I'm in one of the major urban centers. The point being that it's not just a rural issue, it is a systematic issue, and I don't think Montana's a whole lot different than a lot of other states. I mean, we just don't have enough, in general, mental health providers. So, though I don't want to, well, I guess I have already done it, but I don't think the issue is going to rural communities. I think the issue is really, I mean, it may well be, and I think those people just have a harder time, but the people in Missoula and Billings also, as the primary care docs in Missoula and Billings also have a hard time getting adequate access. Even though we have a mental health center, it's almost impossible to get a patient into the mental health center from your practice. So anyway, I just wanted to add that in.
I really appreciate that comment, and I don't disagree with you at all. I think one of the reasons and there's so many different definitions of rural. I think one of the things I wanted to emphasize that I had sampled from folks in those communities of 10,000 or less, because I think their voices are really underrepresented and they have some unique challenges. But you're right, the overall sample, it was very clear that these are challenges for everybody. And access for mental health is a really critical issue. You have FQHCs and community health centers that are funded to be safety nets and treat people who don't have insurance for health problems. Our mental health system isn't funded that way. Our community mental health centers, they're nonprofits. They don't get money to take care of people who don't have insurance, which is why they're coming to primary care settings. And the vast majority, you know, say in Missoula, most of us who do private practice, we're working with folks who have better insurance. And so the folks who don't have, especially who don't have resources, they still have very few places to go. Nonetheless, I would say that with the statistics in terms of all the problems, when I compared communities of 10,000 or less with those of 10,000 or more, there was a statistical difference between those two populations. So the problem is widespread, but it's even worse in the smallest towns. Yeah. But thanks for your comment.
And I'll put a plug in for nursing homes where the needs are bottomless. Bottomless. Okay, thanks everybody.
Yeah, thank you very much.